Thank you so much for the opportunity to share some data with you. I have had some travel paid for by Intuitive. So the goals of my talk today are to understand areas in which prehabilitation can improve our patient care, review some of the data to support or refute prehabilitation, and also to provide a little bit of resources for us all. So we know that there's lots of different factors that might contribute to poor patient outcomes. The most common ones that we can think about are frailty, malnutrition, poorly controlled diabetes, obesity, and smoking. And so those are the main topics that I'll cover with us today. And we're trying to shift the paradigm. It's probably been in the most in literature in the past 5 to 10 years that we're switching from a thought process of operating on people and then providing rehab to them afterwards to seeing as to how we can improve their health before a surgery to see if they'll have better outcomes afterwards. And this is really more of a novel thing that's sort of followed in, along with ERAS. And so, all of us as surgeons are much more likely to offer an operation sooner to a patient who's, healthy, who's has a great A1C, who's on a good diet, and who exercises. But the question is, how can we improve the care for the patients on the left side? There are some naysayers and some data to suggest that perhaps, prehab can lead to bad outcomes. There was a recent paper in Journal Surgery News where the OHSU hernia folks presented their data, and then even in the commentary, one of the critiques is that prehabilitation would delay care for patients. And so it's not always a great thing, potentially. And so kind of getting into each topic today, there are different ways of measuring frailty. We typically think about elderly age as one factor, but there's data to show that it's much more complex to that. There are many different ways of measuring frailty, including specific measures of frailty indices that are based on their function, their cognition, how fast they can walk, grip strength, and nutrition levels too. There's some really strong data to show one paper in 600 patients of thoracic or abdominal surgery looking at 90-day morbidity outcomes found that frailty and sarcopenia both were major risk factors for having postoperative complications. Looking at in a hernia collaborative registry of small hernias getting repaired, they were able to look at frailty-adjusted indices. They accounted for differences in operations and hernia characteristics, but they did see that patients with frailty were much more likely to have any complications, serious ones, and even SSIs and adverse events after discharge. So this just tells us that if you're frail, you're going to have more bad outcomes. So what is the data on prehabilitation? There hasn't been too many, but the largest meta-analysis of 15 RCTs, which all did not have too many patients per study, did find that there are a significant decreased odds of morbidity for prehab programs, and also for pulmonary comorbidities and length of stay did not show any difference. There were a few trials that showed a little bit of improvement in breathing, or inspiratory pressure, and in tests that were looking at walk speed, that prehab did not actually make a difference overall in the meta-analyses, but some of the trials did show some difference. There was one actual RCT in Barcelona where they randomized patients to a personalized physical activity program and endurance training, and they did see that there were decreased risks of complications and ICU length of stay. And then just getting into sort of the more recent studies, I was able to find two. One was a randomized control study of colorectal patients who had poor METs before surgery. They were randomized and controlled by the type of colorectal cancer and disease and what operation that they had. Most of them, 77%, had laparoscopic surgery, and they did have a high 58% complication rate. They were randomized to 3 times a day say over 3 weeks of prehabilitation before surgery versus usual care, and they were able to find significant decreases in 30-day postoperative complications with a with a relative risk of 0.6. When they were able to control for all the other multivariable factors, they found an odds ratio of 0.2, but they did not find a difference in readmission. I think the largest or one of the more famous studies that come out more recently was published in JAMA in 2020. They did a single blinded parallel arm RCT where they randomized patients with high frailty index scores to a multidisciplinary prehab approach of exercise, nutrition, meeting with dietitians, and cognitive help with kind of nurse navigators before surgery compared to those same interventions after surgery. Most of them had minimally invasive surgery, 80%, and they had a mean age of 78. What was interesting was that they actually found no difference in many outcomes. So no difference in complications, length of stay, ER visits, readmissions, or in patient factors like overall health status, anxiety, depression, or energy. Some of the limitations of the study that could be pointed out as to why they found no significant results was that they all were part of an ERAS pathway, and the control group was still got an intervention of rehab compared to prehab. And also the other thing is, is 3 weeks of intervention enough to make a difference? So I would say that all of this data suggests that maybe it's helpful in the frail population, but I think the data is still relatively mixed. Moving on to a different topic about malnutrition, we do know, based on lots of different studies, that having malnutrition increases risks of postoperative complications. A large study showed the odds ratio of greater than 4 in over 200 abdominal GI operations. And one of the largest studies in the VA found that the albumin level was the #1 predictor of postop morbidity. There's been some other data in more specific trials looking at malnutrition, for example, in esophagectomy patients. They found that moderate to severe malnutrition led to higher risk of Cleveland-Dindo 3B or higher comorbidities morbidities after surgery, also higher respiratory and cardiac complications. What was interesting was that this was only found after open esophagectomy as opposed to laparoscopic minimally invasive, and that some other studies that looked at nutritional support with tube feeding interventions also did find that it did lower postoperative complications and length of stay. Moving on to the field of diabetes, we do know that one of the things that we commonly quote is that poorly controlled diabetes can likely lead to increased surgical site infections and wound issues. One of the largest studies from UCLA looked at over 3,000 abdominal, vascular, and orthopedic operations, compared to a reference group where the A1C was less than 6.5. The higher the A1C, for example, 8 to 10% had an odds ratio of 2.4, and greater than 10 had an odds ratio of 3 that led to postoperative complications. Other large studies, meta-analyses show similar findings of higher leak rates, wound infections, and complications. And this was also the same from the Henneford group for open ventral hernia repairs. Similar to the esophagectomy data, though, what we're also seeing is that diabetes may not have the same impact when minimally invasive surgery is then brought into play. They were able to find that that poorly controlled diabetes didn't actually affect SSI rates after minimally invasive esophagectomy as well. And one of the largest MBSA QIP studies for bariatric surgery also found, after adjusting for comorbidities and surgery types, that A1C did not actually affect postoperative complication rates. I think this is something that we all know, that smoking leads to poor outcomes in terms of wound complications. This has been shown over and over again in general surgery literature, like in ventral hernias. A large systematic review also found higher risks of wound healing and pulmonary complications. And that stopping smoking led to a reduction in those complications. Contrary to what we would think, though, there's been some maybe more controversial papers out there that show that for those undergoing minimally invasive ventral hernia repairs, either laparoscopic or robotic approaches, that there were no differences in surgical site occurrences in active smokers versus not. And some surgeons are arguing that we don't have to have patients quit smoking, and I think that is a little bit counter to what at least my core belief is. And sort of lastly, getting into obesity, I think what we typically think about is that obesity can increase the rate of hernia recurrence. There's been some studies, but not many out there, that have looked at sort of earlier outcomes. One group found that amongst 200 or greater robotic hernia repair patients, where they matched those with obesity class 2 versus 3, with a mean BMI of 37 versus 45, that there were actually no differences in surgical site events, infections, or occurrences based on BMI cutoffs, and no differences in hernia recurrence. The argument here is that with a minimally invasive robotic approach, you can put in larger pieces of mesh that provide wider coverage, and this might kind of overcome the hernia recurrence rate in patients with obesity. There have been some studies to show, though, that when you have patients exercise, it's not directly related to obesity, but when a study using the Abdominal Core Health Quality Collaborative Registry found that when they stratified patients based on their preoperative activity level, those who have more daily activity, who work out, have fewer complications and readmissions, which is not that surprising. I think one of the things that's a little bit harder to, or one of the critiques of prehab, especially in the obese population, is that prehabilitation can delay surgery, and many patients won't be able to get their surgery because they can't lose the weight. There's been some data to show that weight loss is feasible and patients can get their operations, but there's very few studies out there. Out of OHSU, Vahan Nicolian's published about a series of 100 patients, many of them who had obesity, diabetes, who were active smokers. They enrolled them in a multidisciplinary prehab program, and they were able to find that about a third of their patients were able to optimize a lot of their comorbid statuses and get their elective hernia repair. A third of them were able to get partial optimization, and several patients could not get fully optimized and needed emergency surgery, which is not, surprising. Another study of 200 patients saw that only 18% of patients could actually get to elective hernia repair after achieving a degree of weight loss of a BMI of 35 to 33 on average, but that there was still a 7% emergent hernia repair rate. They found that those with obesity did have a higher hernia recurrence, and that patients who needed emergency surgery also had a higher length of stay, which is not surprising. I think we don't have, the VA inguinal hernia trial at this point to see whether, watchful waiting optimization will lead to, higher risks of complications in emergency surgery yet. But those are the types of, studies that I think we need in the field going forward. There's been a few other small publications that have looked at whether obesity treatment and optimizing before hernia surgery is feasible. Out of Mike Rosen's group, they instituted a very low-calorie weight loss program in only 25 patients, but they were able to achieve a mean BMI decrease from 49 to 40. Out of the Michigan group, many patients who had complex hernias, who had a high BMI, who were smokers and elderly, they were able to get 9% of patients optimized. So it's a little bit grim, but it's still possible. So of the studies that looked at multidisciplinary hernia prehabilitation, there's been only one or two studies. One did show that multidisciplinary hernia prehabilitation versus usual counseling did lead to significantly fewer hernia-free complication rates at 1 month after surgery, but the long-term data at 2 years showed no difference and no changes in their hernia recurrence rate. So I think that this is one area that we just don't know enough about. I'm almost done. I think one of the things that can be quite helpful to us as surgeons that helps get patients buy-in is, for at least for me, for the hernia patients, is the CEDAR risk calculator. We put in, patients' characteristics, diabetes, smoking, their BMI, and we can literally show patients, what their risk of postoperative complications are. And this is for a diabetic, a smoker, has a complication rate of 45%. And I love showing them that if they get their diabetes under control, their risk goes down to 35%. If they quit smoking, their risk goes down 22%. If they lose 20 pounds, then it goes down 80%. So these numbers this app is very helpful to get patients to buy in, but we're always having to balance how much optimization are we actually going to achieve, how much further can we delay their operation. I think today I've kind of covered most of the topics. I think the data is out there to show that interventions on frailty may be helpful. Other areas show stronger data, except maybe obesity. And there's enough data to show that outcomes are definitely better in prehab for open surgery, but the data is mixed and more equal after minimally invasive surgery. There's a great kind of framework that was published recently with the reference there, but whenever we see high-risk patients, we can think about all the different ways that we can optimize them through weight loss, optimizing their diabetes, thinking about substance use, and one easy thing that we can test in the clinic is a timed up and go test. So have patients sit in a chair, ask them to stand up, walk 10 feet, and walk back to the chair. If it takes them longer than 12 seconds, then we know that they're at higher risk for frailty, and that we can think about more interventions that we can help them with. Thank you very much.